Thanks IIP Latur and MARPCON for actually inviting me, and thanks to all the members, Mahesh and Suresh, for chairing the session. I think I'm going to start the part of oration here. The topic of the oration I heard from Dr. Jog is going to talk on right turn after 40s. So I think we all, as a pediatrician and neonatologist, everyone has done 10 years of practice. Everyone is happy with the practice. Everyone is checking 100 pediatric patients per day. Everyone has 40 to 50 bed indoor patients. But friends, it is a right time now. I think I could see my students also, my colleagues also, Yogesh and Deepika, Sachin, Preetam, you need to take a right turn in academics. Sir is going to talk about the other right turns, which I know. Dr. Jog, he is going to talk different turns. But as academician, I would like you to think about turns, about the important aspect which I am trying to say is what we are trying to learn. Greeting from my city, the capital of India of 17th century, you all know. So we will go and we'll discuss about the next 40 minutes about the sepsis and POCUS and the hemodynamics. So let's see about how this ultrasound is going to help us in our day-to-day practice. We know that everything we know about sepsis and everything we know as a gram-negative sepsis. When it comes to sepsis in India, we always talk about this Klebsiella or Pseudomonas or Enterobacter E. coli, everything. We know that. We know issues with when I'm practicing, suppose in Latur, I know the various parts of Latur, Marathwada or everyone. The first thing comes in my mind is a financial morbidity. So definitely, I need to think about the finance of my patient, and the second part comes is the mortality. We know that one. But before that, I would request all of you, please concentrate on blood culture. Develop habit, send the blood culture, believe the blood culture, and think about that. We all are doing about fantastic work on the blood counts. No need to say that. Everyone is working on blood counts. Everyone is interpreting about the CRP, which I don't want to comment and which I don't like. The test which I don't like in pediatric practice is the CRP, but I don't want to comment here. You decide what you like. To me, I don't believe this test. That's my problem, but we need to work on. What is my role to you today is just to sensitize this gathering today is how I can develop interest in you in the next 40 years of your practice as the future of pediatrics, which is called as insonation. Friends, the inspection, palpation, percussion, auscultation will remain lifelong. Whatever technology comes in the world, it is not going to change. It is going to be there all the time. Somebody says that, oh, I have done something new, but these changes will not happen. What we are going to add is the fifth pillar of that is insonation. So when we are discussing about the insonation, it is a time to all of us to adapt that ultrasound is a part of our practice. And that's what I want you to take a turn in your life and think that can I utilize this ultrasound? Today morning I saw a lecture from Dr. Somani about the bronchoscopy. You need to think. Similarly, the ultrasound, which is the bedside, you need to think. What ultrasound I'm talking? You have a question in your mind. That question, you on bedside, you take a decision on that ultrasound report, what you have done, because you are the clinician. You know the problem. From that problem, you need to act and treat the patient. That is called as a point of care ultrasound or POCUS. I was talking with the Dr. Sudhir Mure in the morning about his photography. That's a turn after 50. I am talking you to academic turn after 40 when we are thinking about these ones. How the ultrasound helps me. This is the article I have written for Indian Pediatrics. Just now, hopefully it will be published in next 2 months. That diagnostic facility, critical assessment, the screening and monitoring, procedure and the research. Now you will say, sir, don't talk research. We are in periphery. Please remove that mindset. You are the one who are checking more clinical patient. In the cities, you are getting less academic work. In the periphery, you have more academic work. Hence, you should do more research. I'll come to that point, how the research changes. So this is the chart which Asian Society, probably I represent the Asian Society for Ultrasound in Neonatology. We have developed, and again I told you that this article I have forwarded to IP, that we need a cranial ultrasound, lung ultrasound, gut ultrasound, hemodynamics. Just the previous panel has discussed about the hemodynamics and IVC. The hemodynamics I'm going to talk, lines position, procedures and research. Those young budding neonatologists, when they are working with the lines and then they are working with the procedures, you can't escape about ultrasound. Ultrasound is mandatory, it's a part of your life. What does ultrasound tell me? Does baby has a PDA? Does baby has a pulmonary pressure? Does baby has issues with the cardiac output, issues with the volume, and which inotrope I should use? That means my whole neonatology is here. Does baby has a bleed? Does baby has infection? Can I diagnose effusion? Can I diagnose pneumonia? So can you think about that? Your practice is on the basis of ultrasound. This is the commonest thing what you find. The pneumonia and the pleural effusion and pneumothorax. This is the common practice in your respiratory medicine. What do you need more than that? Lines, when you are putting endotracheal tube, UAC, UVC, you need to confirm that. You don't require X-ray. X-ray takes 10 minutes. X-ray takes 1 hour. Avoid that. Immediate actions can be done by the ultrasound, like gut ultrasound is ascites. That's what with this one. Now I'll be taking one case. And in that one case, you will know how the ultrasound has helped me. So this is the baby, common baby, you all have seen. This is the one, 34-weeker, came to your hospital as outborn with apnea, bradycardia, hyperglycemia, lactate high, effusion problems, with hypotension. Nothing fancier. You all know that. This is a case of gram-negative sepsis. You know everything. You know that you are going to start antibiotics. I know that. But how this research has changed my practice, which I am going to tell you. This baby's functional echocardiography showed pulmonary hypertension. This is the TR jet. This is a pulmonary hypertension. So the sepsis with secondary pulmonary hypertension, this is the paper published by our team, published in the Journal of Ultrasound by Italian journal. What it shows, the babies of secondary pulmonary hypertension, that means babies with the gram-negative sepsis has a pulmonary hypertension. So first thing remember, in India, gram-negative sepsis, secondary pulmonary hypertension, one statement. The second statement, what we saw, that these babies have bidirectional PDA. The babies with the gram-negative sepsis have a PDA. Don't treat that PDA. Once you treat the sepsis, PDA gets closed. Another paper which is submitted to the pediatric research, which will be coming out in next 2 months. So PDA is common. You don't require ibuprofen, paracetamol for that PDA. Second statement. Third statement, these babies have a high cardiac output. The gram-negative sepsis in India have high cardiac output in spite of hypotension. And that's one more paper published by our team, that the cardiac output in late onset sepsis, very high cardiac output. So third statement I am making, hypotension as you know, pulmonary hypertension as you know, high cardiac output you know. So dear friends, which type of shock I am dealing? There is a hypotension, there is a cardiac output high, that means my SVR is low. So I am dealing with a vasodilatory shock. So what research has taught me? The Indian gram-negative sepsis who are presenting to us, they are vasodilatory shock. On that basis, what I need to see the ventricular functions. So hemodynamics has shown me that these babies with a gram-negative sepsis has a biventricular dysfunction. So pulmonary hypertension, high cardiac output, biventricular dysfunction with hypotension. 4 points we learned. With these 4 points, we also saw these babies have ascites, these babies have pericardial effusion, these babies have the pleural effusion, third space loss. So in India, sepsis has a third space loss, sepsis has a hypovolemia, sepsis has a volume loss, what we learn. So this is the one chart I have covered in the research about the 5 publications. That we have third space loss, we have hypotension, high cardiac output, pulmonary hypertension, myocardial dysfunction, and vasodilatory shock. So if I know from this research that the things are changing,
what should I use? Can I use dopamine? Which is the common drug which you are using? What is the common treatment here? Dopamine, dobutamine, combine and you start. Now I will change your thought process. Let's give me 2 minutes. Epinephrine, norepinephrine, vasopressin. Now we learned that there is a pulmonary hypertension, there is a hypotension. The dopamine increases the SVR, but dopamine also increases the pulmonary vascular resistance. So what's happening? Dopamine is actually worsening your pulmonary hypertension. So what we saw in the research, these levels of pulmonary hypertension, I am using dopamine, increasing the pulmonary vascular resistance. So friends, be careful. What about epinephrine? It is a fantastic SVR. It is a good inotrope. No action on pulmonary vessels. So one drug which is good for these babies is, yes, epinephrine. But what I want to trace today, norepinephrine. When it comes to PICU practice, we use norepinephrine. When it comes to NICU practice, we are not using norepinephrine. Why? Don't know. Let's see. Fantastic drug to improve SVR, decreases the PVR. Friends, remember, I told gram-negative sepsis as a pulmonary hypertension. So I need a drug which will reduce my PVR. And this is the drug. And that's what we need to think about this one. Vasopressin, similar like norepinephrine. Increase SVR, decrease PVR. Then dobutamine, only heart action. Then I am talking the milrinone. It decreases SVR, it decreases PVR, but the main action is the heart. So pulmonary hypertension decrease and heart action is important. So if I revise myself, I will not talk about nitric, I will not talk about sildenafil. That the babies with the septic shock in India, they are hypovolumic. Volume is very important. We discussed that, volume. We saw ascites, fluid effusion, pericardial effusion, third space loss. So the babies with the sepsis, volume loss, think about that. The babies with the sepsis have high cardiac output and pulmonary hypertension and vasodilatory shock. Hence, in these babies, my drug of choice is norepinephrine, which will improve my systemic vascular resistance, which will decrease my pulmonary vascular resistance. I hope this is clear. This is the first message I want to go. But this was a theoretical thing. Can I prove by research? This is the article now. Hemodynamics effects of noradrenaline in septic shock. It's been in BMC Pediatrics, accepted in BMC Pediatrics. 30 babies with the shock. Use of noradrenaline improved the blood pressure, decreased the pulmonary hypertension, improved the oxygenation index. So friends, when you are thinking dopamine, dobutamine as a combination, that era has gone. Think about this one as a drug of choice in a gram-negative sepsis in India. That is what I am talking. One step we go ahead. One of my DM candidates done this research. Adrenaline versus noradrenaline. So we use the noradrenaline. Can I manage adrenaline versus noradrenaline? So we saw that the response is good with the both drugs. Hence, noradrenaline is a safe drug in the Indian setup as a gram-negative sepsis when there is a pulmonary hypertension. Hypotension is there. That's what you are giving the inotropes. That's what you are giving the vasopressors. But to reduce that pulmonary hypertension, you need a drugs which will reduce your PVR, and these are the drugs. Can I use the milrinone? I told you that sepsis has a biventricular dysfunction. So friends, milrinone is a good drug in this gram-negative sepsis for combination to improve your ventricular dysfunction. And that's one more paper published by our team which improved OI, decreased the pulmonary hypertension, improved the ventricular functions. So what the research taught me, this is the one slide you remember. What my research has told me that in India, this gram-negative sepsis has a volume loss, give the volume. This gram-negative sepsis has a pulmonary hypertension, noradrenaline and milrinone will take care. This sepsis has hypotension, high cardiac output vasopressor, noradrenaline will take care. So do our own research. Don't think that we cannot do that. Every time we cannot tell the papers from the West. So I think all my young gun students or my colleagues, think about that. Suppose Sachin, Deepika, Yogesh or Preetham who are working in periphery, you can't do some things. It's not like that. This is a simple technology of ultrasound which I am trying to tell you. The future research going on in my unit is noradrenaline versus dopamine, noradrenaline versus vasopressin. That research is going on. So friends, we saw the echo. Can I see these other things? Yes, this baby, just see this baby. This is nothing, simple pneumonia. This is the lung ultrasound. The simplest modality on the earth is lung ultrasound. You can learn in a one-day session. And I request all pediatricians and neonatologists, you all are neonatologists, to learn lung ultrasound. Because every day you have 5 pneumonias in your IPD. They all are admitted. And that's the need of India. And that is what I'm trying to say. Please learn that. This baby, I wanted to do the lumbar puncture. This is the spine ultrasound. These are the vessels marked. And this is what you can see, the needle, ultrasound needle coming here. Can you see this needle? Lumbar puncture done by ultrasound. Utilize the technology. Everybody has iPhone. Everybody has Samsung, falana. What I don't remember the sequence. Everybody has a very hi-fi laptop. So why can't you use this ultrasound as your day-to-day practice? It will come. So friends, you see this baby's brain ultrasound. Dilated ventricles. You don't require radiologists to diagnose these dilated ventricles. This is ventriculitis. My management changes. This baby with sepsis has a ventriculitis, meningitis. My management is 4 to 6 weeks. Suppose Santosh is managing his NICU with the Yogesh and all the team, and he sees this ventriculitis. They can't give antibiotics 2 weeks and 3 weeks. You might require 4 to 6 weeks. My duration has changed. This is the brain abscess, diagnosed by ultrasound, published in IJP. Antibiotic 6 weeks. This is the subdural empyema. And don't think that these are tough things. These are simple things. I'll come to that, how this is simple thing. So this is the RI, again published in the Journal of Neonatology. The RI is universal. That means the bad outcome. What you can do? This baby requires intubation. This is endotracheal tube. You can confirm the endotracheal tube by ultrasound. You don't require X-ray. That means you are saving patients 500 rupees. 5 X-ray, 3,000 rupees. In even Latur, X-rays are costly. So friends, think about that. So we did one more research, POCUS in sepsis. Brain involvement is 50%, cardiac involvement is 80%, lung involvement is 30%, abdominal involvement is 10%. What does it mean? All organs we need to screen to see these ones. So friends, this one case, sepsis with high output, with a hypotension, high cardiac output, vasodilatation, ventricular dysfunction, third space loss, volume, noradrenaline, adrenaline, millinone. So many things we did on research. It has changed the brain management, lung management, lumbar puncture, endotracheal tube position, duration of antibiotics, prognosis, counseling changes. You are going to do same thing what I am doing, but I am doing slightly little bit turn after 40. I have taken a little bit turn. Sachin was asking, sir, how you are managing 3 NICUs, how you are doing that. I said I have taken the turn. Now I am not taking phone calls. I am doing only ultrasound. I am doing echo. I am doing research. Something we need to take the turns. That's very important. So friends, when we are talking about this lungs and gut, now let's think about some of the findings which are easy findings in the lung, brain. Meningitis, ventriculitis, hydrocephalus, abscess, calcification, candidiasis. These are the common things you see in day-to-day practice. This is very routine. These are the increased echogenicity. That's meningitis. These are the ventricles with septation inside the ventricles. This is ventriculitis. You don't see such septum. That is a bad things. This is the baby with the day 1, 24-weeker. Thrombosis, embolism. What is this? This ultrasound has showed fungal balls. I'm not saying 24-weekers you say in Latur, but 26-weeker candida infection you can diagnose. This one I have done the ultrasound and then the blood culture came on day 3. Immediately the baby was started on therapeutic fluconazole on day 1. That's the importance of this brain ultrasound. These are the calcification. You saw so many torches group of infection. That's the immediate diagnosis, torches group of infection. So friends, we saw all these ones. Along with that, you always struggle with the baby who deteriorates on day 3 weeks, 4 weeks, with full feeds and deterioration. And that full feeds baby deterioration turns out to be the ascites, portal vein gas, and nematosis. This is the gut ultrasound. You diagnose the nematosis, you diagnose the ascites. What do you need? Whole neonatology I am talking in one class. That is what is the role of this one. These are classic nematocysts. So friends, it is all easy. Those people who are interested in infections, this is our book. Some of you already got this book is available. You can request this book I have given to the Nestle team. You can request, they can give you guys the book that you can decide. What about the lines and procedures? This is the backbone of neonatology or pediatric intensive care. Without that we can't survive. What about that? So you see this line is low, this line is high. That's a UVC. UVC is going in heart, not good. This UVC is in the heart. This UVC, when we see here, this is the normal position. This is the normal position of the UVC. These are the normal positions of UVC. So the ultrasound confirms the line position. And I don't have to tell you that complications of line related. By ultrasound, you can put the PIC lines. I'll just show you the pictures, then you will understand. 1 second I'll take. Just concentrate here. This is the artery and this is the vein. And this needle is piercing this vein. This is the ultrasound, very simple way. Now you see this needle is reaching to the vein. This is the echogenic needle. And that's called as eyeball, where you see the echogenic center needle is inside. You see the needle is piercing into the vessel. So do something different. Innovations is the norm. You cannot say that in the next century I'll be continuing my pediatric practice like that. No, we need to do innovations. That's a pericardial effusion, 2 o'clock in the night. If you can't drain this, baby is going to die. Pericardial effusion, drain, that's normal. These are the pleural effusions. Day to day you see so many pleural effusions. Pleural effusion, you can see the needle coming into that. That is the thoracocentesis by ultrasound. These are all simple things. This is the ascites. You see the massive ascites. And in that massive ascites, again the needle, it will show the needle which is entering. That's a simple thing. So friends, what I'm trying to say, suprapubic aspiration, that's a bladder. How to do? Today is not the time to talk how to do, but this is how simple I'm talking, that research can be done in this one. In the next 10 minutes, I'll be talking on the research. A lot of people say we can't do the research. Yes, I was talking with this Dr. Adate from MGM. We need to think about your 30%, 40% time for medical school, 60% time for your practice, because that's your earning. But if you remain in academics, then you will learn more. And let's see about the research. So what, friends, we have done when it comes to India and when it comes to POCUS, our team has done maximum research in the Asia. We have published so far 24 articles about the ultrasound. So many I already showed you about the sepsis related article. These are in pipeline. These are ongoing research. These are the PPHN related research. Somebody must have seen oral sildenafil versus the IV sildenafil in PPHN. That's the research we have done, and that has changed the world. World was talking only IV sildenafil. We are talking about the oral sildenafil, and that is what the first landmark paper in the world, where we published in the BMC Pediatrics, as oral is effective and less complication than the IV. And that is where you should use the oral sildenafil. The Dopplers in HI, hypoxia babies. Do the Doppler after 24 hours. Doppler will guide you prognosis of that HI baby. It's a need of hour. We cannot say that I will wait for MRI on day 10. Don't wait. 24 hours, do the ultrasound, you get a guide, and that's a systemic meta-analysis published in basically the Child Neurology, very high-intake journal, where we publish this systemic review that the Dopplers are useful, and hence utilize this one. We just see the eco experience of India, and we saw that eco helps in India, and that's the major issues. We also saw the growth restriction. Growth restriction and the research, it's very common, and hence we saw the hemodynamics of delayed cord clamping and ventricle functions and cardiac output. Those are the research our team has already done and published in various good journals. So what I'm trying to say that research is feasible. Yes, medical schools need to take that. I could see 2 or 3 professors of medical school sitting in this audience. Please take out that and think about that one as a research part. So there are plenty of research our team has done. Already a lot of lung ultrasound related research ongoing. In the next 6 months, you will see that those research will be out, and those are changing the things. What we have done, we have prepared the training material. Our team has made books, book chapters, national, international guidelines, and a lot of review articles. I think my friends, a lot of you know that these 5 books about echo, lung ultrasound, cranial ultrasound, the cardiology, and FECO-made BZ, all these books are written by our team, and they are available for DM course, DNB neonatology course. But I'm not saying that for DM and DNB. I'm saying that for you guys. Because it's a time now we all need to adopt this 5th pillar of examination. These are the various book chapters related to ultrasound. This is the book of clarity, where the book shock, IIP neonatal chapter, various chapters we have written that one. This is the last month only. These are the guidelines, international guidelines. We are the 13 members from the world. We have written, that's myself, I represented Asia. We have represented when the baby crashes, what focus ultrasound we should do, and that's the European Journal of Pediatrics, where we should do this screening, and that's where you can lead. It's not like that, we cannot lead. A lot of you know that I'm born in village, and now we are leading in the world in the POCUS. So you can lead, whatever technology, whatever interest you have, you can lead in the world. Think about innovations, think about the difference. We all are very qualified people. We all are gold medalists. During our time, pediatrics was the leading branch. So think about that. Don't think that we cannot do. We all can do. Think about that. These are the Indian guidelines about the cranial ultrasounds and those ones. These are the various review articles, lots of review articles written in various journals. And we have taken lots of workshops. And we have started a new concept about taking this international hemodynamics workshop. And I must happy to say that I have taken almost workshops in various countries like Dubai or Myanmar or Sydney or Oman, Sri Lanka, various countries. The last workshop I have taken basically in the Turkey and the UAE. Those are the 1-2 workshops. One new concept I started. A lot of people were worried about the COVID. Yes, we all were worried about the COVID. We transferred that COVID to online sessions. Everybody said that. How you will teach online ultrasound? And friends, today I have students from 20 countries, and they are not only the Sri Lanka, Nepal or Zimbabwe. They are from US, UK, Canada, Australia. So friends, you all can do sitting at home. Sit at home and lead the world. Don't think that you cannot take the turn after 40. Take the turn after the 40. But show the world you are good and you can do good in the life. These are the 4 batches of the new POCUS we have conducted. So far we have trained 190 people from 20 states. Happy to tell you that one of the guys from Latur, Dr. Birajdar, has joined for the 4th batch. He is somewhere here. And I think I request Dr. Sonar or all the Dr. Suri, those who are very, very good academicians, think about ultrasound as your future. Because that's the need of India. The new POCUS has changed professional development. Brain ultrasound, cardiology knowledge, echocardiography knowledge, diagnostic, colleagues, collaboration. In this hall, I know 50 people. How come? Because of these collaborations, colleagues, I know each other, overall educational things improves. So friends, what I want to tell you, ultrasound is the next stethoscope. I have taken very fast. It's not feasible to sensitize in 30 minutes. Initially they told me 40 minutes, but I could see the people sense 1 hour late. So I said, okay, let's cut down to 30 minutes. And this is the stethoscope which you need to think about the critical assessment, screening, procedures, confirmation of lines and research. This is where young ones should come out. Money is the byproduct. You should earn the money. Definitely. I'm not saying that. But if you do the research, it will be there on all the world, your name is there. Money will not be there when your name, but when I die, I don't know how many after years, the name of the POCUS will remain there. So do something different, what I'm trying to tell you. Friends, the portable bedside ultrasound is the visual stethoscope of 21st century. The IT peoples are governing the world. Why can't you become the ultrasound IT? Why can't you learn that one? So friends, those who are young researchers, including me, I'm also young. Don't think that I'm 50 means I'm old. I have taken just guidance from Dr. Sudhir. Mahesh is my inspiration. He always does fancy things and all fitness. Pritam, our own fellow champion from Umarga. Fantastic exercise, fantastic dog-loving habits. And thanks to his father, he has allowed all these habits. So young researcher, working for success will make you master, but please work for satisfaction. Once you work for satisfaction, everybody will remember you as the legend of that field. Select one field. Select one field, whatever you like. Don't select 10 fields. One field of that area, you will be the legend of that field. People should remember you have done that, and people should salute you in that field. With this, I will say thank you IIP Latur, and thank you friends for patience hearing, and please encourage young guns and learn more ultrasound. Thanks for patience hearing. Thank you. Always.